So today we're going to be talking about thyroid point of care ultrasound. I'm Deanna Dourado, and in a little bit you'll hear my colleague Abida Babu. So the point of this lecture is to just go over the basics of point of care ultrasound. So this is distinguished from when you would get like a formal ultrasound, but this is more to be performed at the bedside as an extension of your physical exam. If you have a suspicious symptom or physical exam finding that would have you to suspect some thyroid pathology. So we're going to go over the basics of how to perform the scan, what the anatomy of the thyroid and the surrounding structures looks like on ultrasound, evaluation of nodules on ultrasound too. That's probably some of the meat of the presentation, because that will be the most common findings. Also, some diffuse pathologies of the thyroid, such as Hashimoto's, Graves' disease, some other things in the neck that you could see, and limitations of the ultrasound as well. So the importance of point of care thyroid ultrasound. Ultrasound is actually the best screening and diagnostic test for evaluation of the thyroid gland. It gives you the most information and helps you make a lot of decisions. It's usually better than CT and MRI. And you can see nodules up to 2 millimeters in diameter, whereas normally, if you were palpating a thyroid, usually the limit is like you can feel if it's greater than 1 centimeter. And there's lots of pathology in the thyroid, but that doesn't mean it's all malignant. So the majority of the things you will be finding are usually benign, but it's important to distinguish like benign nodules from malignant nodules, and this can kind of help you with that. So some of the reasons why you would want to perform a bedside point of care thyroid ultrasound, some presenting complaints that might prompt you would be like shortness of breath, cough, irritability, palpitations, precordial discomfort. So essentially like maybe some symptoms of hyperthyroidism or hypothyroidism as well. Palpated masses, or like a goiter, anything visual or that you feel. Anything found maybe on other methods like CT scans, frequently an incidental finding. Again, like more physical findings of hyperthyroidism, such as heart abnormalities, any diseases of the ear, nose, and throat organs, such as larynx, pharynx, trachea, any dysphonia, aphonia, maybe thyroid's compressing like on your laryngeal nerve, dysphagia. The esophagus can be visualized as well on ultrasound in the neck. And then some of these may be more relevant for like endocrine or surgical subspecialties, because you could actually follow like nodules or masses in the thyroid after treatment or post-operatively. So how to do it? The best probe is the linear probe because it is such a superficial structure. You really don't need that much depth and the extra detail that the linear probe allows for. Really allows you to see the anatomy very, very well, the blood vessels and even the lymph nodes and the parathyroid sometimes. And the best way for the patient to be positioned is usually supine, with their neck in a hyperextended position. And for comfort, a lot of times it's best to roll up a towel and put it underneath their neck, especially for people with like short necks or like thicker necks. You really want to be able to open up that space so that way you can get to the thyroid, which is usually just above the supraclavicular notch. So there's two main views that you can get of the thyroid with ultrasound. The top one is a like transverse view. You can see this would be the probe, and you'd be scanning kind of up and down, inferiorly and superiorly. And this is what the picture would look like. You can see the normal. This is a normal thyroid, and it shows up pretty homogeneous and like hypoechogenic. And then you could also get a more longitudinal view. You can scan right and left, and this is what it would look like. So just to review some of the pertinent anatomy of that region, because it is kind of complicated. There's a lot of structures, but the ones that you would mainly be able to see with the thyroid, obviously the thyroid itself, and if you remember, there's a right lobe, a left lobe, the isthmus, and then sometimes you can have a pyramidal lobe, but that is not something that everyone has. The majority of people don't have it. You can also see the blood vessels really well, the internal jugular vein, the common carotid artery, and if you remember, there's 3 veins that drain the thyroid, and then 2 arteries that drain into the thyroid. You can see some of them with Doppler, but that's a more advanced technique we won't be talking about. You can frequently also see some of these lymph nodes if you have a really good eye for it. Sometimes the parathyroids, especially if they're enlarged. Immediately behind the thyroid, you'll see the trachea. You got your thyroid cartilage there. And you got the nerves. You're not able to see those. But it is important to know because you can have some pathology, especially if the thyroid's enlarged and compressing on them. And then some of the muscles that you can see, so you would usually be cutting across like right here to look at the thyroid. You can see the omohyoid most laterally, and then the sternohyoid, and then underneath that, the sternothyroid. And then up at the very edge, usually if you scan over, you can see the SCM quite well as well. So here's a view of what a normal thyroid would look like. And a lot of times your view isn't this wide, depends on your probe. But for the sake of going over the anatomy, I wanted to get a pretty wide image. So here you have the thyroid. This is in a transverse view. Like I said, it's very homogeneous and like say like isoechogenic or maybe slightly hypoechogenic. So here the isthmus is right here. This is the left lobe, the right lobe, the trachea that we talked about. And then you have the carotid artery. The jugular vein would be even more laterally. You actually can't see it in this picture. You can see the esophagus very well. It's like a targetoid appearance a lot of times, and obviously located usually on the left side. It would not be on the other side. And we have also the muscles up here. So the largest one is the SCM, most laterally. Then you have the sternothyroid, the sternohyoid, and you can hardly see the omohyoid right here. And then you have the subcutaneous fat, and if you remember, you also have the platysma up here, but it's too small to see on ultrasound. So the arrow is pointing to the left tracheal esophageal groove, but this was just the image I got. There was no real reason that I wanted to point that out. So one of the most useful things that we can evaluate with thyroid ultrasound is nodules. So it's important to distinguish between what a benign nodule looks like on ultrasound and what a malignant nodule looks like. And this is a table of some of the comparisons between the two. So typically a benign nodule would be more anechoic or hyperechoic, and then a malignant nodule would tend to be more hypoechogenic. Benign nodules can have peripheral calcifications, whereas malignant nodules tend to have microcalcifications throughout the nodule. And we'll have lots of pictures of this to go over in more detail. Benign nodules are more consistent with like a simple cyst appearing structure, as like, we kind of mentioned like an anechoic structure. Where malignant nodules, usually they're taller than wide in shape. Benign nodules can have more of a spongiform appearance or like heterogeneous composition. Malignant nodules tend to be have more irregular margins. They're usually more solid in composition. Benign nodules can have peripheral vascularization, so you can actually use Doppler on it. We don't have any pictures of that, but the comparison would be a malignant nodule would have vascularization throughout the entire nodule, and you can actually see that quite well. And then size, usually benign nodules are less than 1 centimeter, where malignant nodules would be greater than 2 centimeters. Malignant nodules may also have some suspicious lymphadenopathy surrounding. We'll go over what that would look like. And then a sign that we use to distinguish benign and malignant nodules is the halo sign. So a positive halo sign would be a benign nodule, more indicative of a benign nodule. If you remember, like none of these characteristics are 100% predictive of the actual nodule. They're all kind of used to help guide you. The only thing that will definitively tell you if it's a benign or malignant nodule is to actually get a biopsy. So the ultrasound is supposed to help guide you whether or not you should do a biopsy or not. So the three, I would say, best indicators of malignancy are microcalcifications, the nodule size greater than 2 centimeters, and then an entirely solid composition. This table and the next table was taken from a study published by JAMA in like 2013 that compiled I think like 8,000 patients with thyroid nodules and looked at their ultrasound findings and compared whether or not those findings were associated with malignancy or not. And so they found that the three findings most associated were these. So microcalcifications has an odds ratio of 8.1, nodule size of 3.6, and composition was 4. So we'll again go over some of what that looks like actually on imaging. And then this was also one other interesting table. So if you have all three of those characteristics, it's actually almost nearly entirely predictive of it being malignancy. The false positive rate is 0. It's not the most sensitive because obviously not all malignant nodules will have all three of those, but you only need to biopsy one in order to find cancer. But this kind of breaks up two. I won't really go into detail how useful these findings are, but they are all very useful, which is why we're talking about them. So microcalcifications is the first one we'll talk about. So this would be a malignant nodule, and this would be a benign nodule. So the microcalcifications are actually usually so small that they don't create a posterior acoustic shadow, and they're kind of randomly dispersed throughout the nodule, whereas microcalcifications suggestive of benign features would be just in the periphery, like this one. And because it is more extensive, you can see some shadowing from the calcifications. And then this would be an example of a halo sign. So remember, halo sign is more associated with benign nodules, and it's a hypoechoic like rim around the nodule that I'm pointing out. And this was a follicular adenoma versus malignancy, so papillary carcinoma. You can see does not have a halo or that hypoechoic rim. And then the composition of the nodule itself can be helpful. So a more solid appearing nodule would be consistent with malignancy, such as here you can see they look more solid appearing. It's easier to then just compare to like a more benign structure, which is more consistent, like a cyst or multiple cysts, or just a lot of irregularity within the nodule itself. And you can see here there's a couple microcalcifications throughout the nodules, and there's no like halo sign either, whereas you actually maybe will see a little bit of a halo sign there. And then the echogenicity, so like I said, the anechoic and hyperechoic suggest benign versus a more hypoechoic or isoechoic suggests malignancy. Okay. Abida, it's all you.
All right, thank you, Deanna. So I'm gonna go take it over from here. So in this slide, you're going over the diffuse changes that you would see on ultrasound. For example, if a patient has Graves' disease, what are the ultrasound findings that is expected to be seen? You would see a symmetric enlargement of the entire thyroid, and because it's enlarged, it can push the vascular bundles, laterally. And the way you would see it, there's a decrease in the echo density. It would be mostly hypoechoic, and sometimes you can see linear echogenic inclusions. So we'll go over those ultrasound findings in the next slide. Okay, there you go. So if you look at the first one, you can see an increase in the isthmus. It's significantly enlarged. Yeah, exactly. Right where the cursor is pointing. And then if you look at the slide beneath it, where you can see the entire thyroid gland, it looks significantly more enlarged. And you can also appreciate all the linear echogenic structures that I was talking about, which is also characteristic of Graves' disease, exactly. And similar findings can be appreciated in slide B as well. And then we go over to the next one. If you were to Doppler these the images, you can see that there is increased vascularity on color Doppler imaging, and it's commonly referred to as thyroid inferno on color Doppler imaging. So these are some of the findings which can help identify Graves' disease based on ultrasound. And then, um, so you also have multiple other structures in the neck. You have thyroid, you have lymph nodes, parathyroids. So in the image, you can see the most common location for the lymph nodes. The cervical lymph nodes, there's the upper, middle, lower, the groups. And the way you differentiate lymph nodes on ultrasound is mostly lymph nodes are oval shaped, and they are more proximal to the neck vessels. And usually they tend to be less than 1 centimeter, and they would be well defined. These lymph nodes will be mostly hypo or even isoechoic. So the way you can differentiate is if you were to place Doppler on the lymph node, if you are having suspicion if this is a lymph node versus like a vascular structure, if you were to drop Doppler on, and you can see the blood flow. And when you place the ultrasound probe, they should be like painless and moderately mobile. All right, and on color Dopplers, they would be hypervascular. So if you look at the ultrasound findings on the slide, up above you can see that it's avascular compared to the vascular structures on Doppler, and it's definitely hypoechoic. On the next slide, you can see the thyroid structure, like this the slide on the next to the thyroid structure, you can see it's marked. The lymph node, it's hypoechoic compared to the thyroid structure. Thank you, Deanna. Exactly that where she's pointing the cursor. So that is one way you can differentiate if it's a lymph node versus a vascular structure. All right. If we go to the next one, so like I mentioned earlier, there are other structures in the neck, like the parathyroid, and parathyroid can be in different locations. Most of the time, 38% of the times, it's closer to the lower lobe of the thyroid, and it could be in many other areas, but we'll go over how it looks like on ultrasound. The next one, so parathyroids, like I mentioned earlier, the most common location would be the inferior segment or pole of the thyroid lobe, or sometimes it's completely enclosed within the thyroid as well. And they tend to be 0.7 centimeters or less, and they should be like well-defined, round, oval shape, and if they are homogeneous structure. Now, parathyroids tend to be slightly increased echo density. So that's one way you can like differentiate between like lymph nodes, parathyroid, and they will have regular margins. So if we go to the next one, we can see the ultrasound findings. So if you see the ultrasound in slide A, you can see that it's slightly more increased echo density, and they are in different locations. Like, so if you're having any doubts if this is the parathyroid versus like a vascular structure, if you drop Doppler on it, you won't be able to see the vascularity. That's another way you can differentiate. And then next one, so you have different other neck masses as well. You have the midline cyst. That's where most you would see the thyroclosal duct cyst. It could be anywhere ranging from the base of the tongue to the superior pole of the thyroid in the midline. And then laterally, you have the lateral neck cyst or lymph node. So the way you can differentiate lymph node versus a neck cyst would be the cyst would be mostly hypo or anechoic, like most likely anechoic, and it would be like not as oval or round shaped as the lymph node you would expect. And then based on the location of the neck mass, you will kind of get an idea if it's a salivary gland, lymph node, like a cyst, or if it's just the thyroid. And then some other neck masses you can expect, or you can see the carotid paraganglioma. And if based on the clinical history, if it's, if you're looking for like, if it's a cancer patient, if you're looking for mets, and then you can We used ultrasound to like visualize if it's a mass, and then drop Doppler to see if it's vascular versus like if it's a vascular structure versus an actual met. And the next slide, we'll go over the limitations. So like we were going through, sometimes it's easy to mistake, get mistaken for different structures, because you will have, the lymph nodes and sometimes come up, and then you have the vascular structures, and you can eliminate some of them using Dopplers and things like that, but sometimes it gets a little tricky. And again, it depends on how well versed you are with using an ultrasound. The quality of the ultrasound definitely matters. And like Deanna was pointing out earlier, a thyroid nodule, to like differentiate between benign and malignant, there are different characteristics you can use, but you still need FNA to like a biopsy to definitely conclude that it is malignant. And it's not the best for like thyroid dystopia or ectopia, because we don't know where we have to look for it. And that would be all. Thank you.
Thank you.